Welcome to this deep dive. We're focusing today on the management of facial soft tissue trauma, really honing in on the core principles you'll need for surgical board exams.
Right. The goal is to crystallize that essential knowledge. Let's start with the basics. Who gets these injuries? Well, it's pretty broad, actually. No real gender difference. And the average age is around 28.
And it's worth remembering why the face is so important in trauma, isn't it?
Absolutely. It has 5 key functions relevant here: protecting the brain and sensory organs, starting digestion and breathing, and, of course, expressing emotion. Damage can impact any of those.
The causes are quite varied, too. We see everything from, car accidents and assaults.
To animal attacks, wild and domestic falls, even self-inflicted injuries or things happening during sports.
Okay, so let's categorize the injury types themselves. What are the main ones we see?
Sure. You've got abrasions, basically scraped skin, lacerations, which are cuts or tears, often jagged.
Then avulsion.
Yeah, avulsion is where the skin is actually torn away, lifted up. And crush injury is caused by compression. These can be deceptive. Sometimes the underlying damage is worse than it looks initially.
And there are a couple of miscellaneous ones to keep in mind, too, like gunshot wounds.
Ah, yes, GSWs. Important point there. Even if the soft tissue defect looks small, the internal disruption can be massive. You might need early intubation.
And bites. They seem to come up often.
They do, and the big concern is infection. They're often polymicrobial. Human bites, you worry about things like Eikenella, strep viridans,
Dog bites.
often Pasteurella canis. Cats tend to carry Pasteurella multicida, and actually cat bites often have a higher infection risk.
Why is that?
It's the nature of the wound. Deep punctures inoculating bacteria effectively, plus the virulence of that specific Pasteurella strain.
Okay, so moving on to the initial assessment and management,
Right.
what are the absolute first priorities?
A really thorough assessment is paramount. You need the mechanism of injury, a good look at the wound itself, its quality, contamination.
And especially with significant mechanisms, you're thinking broader than just the face, right? ATLS principles.
Absolutely. Always consider associated critical injuries, head bleeds, C-spine fractures. ATLS provides that systematic approach. You have to rule those out.
And locally, on the face, what specific structures need close attention?
You've got to be meticulous near specialized areas: the tear drainage system, the lacrimal apparatus, the ear canal, the facial nerve, the parotid duct.
And nerve assessment timing is key.
Crucial. Test motor and sensory function before injecting any local anesthetic. Once it's numb, you've lost your chance for an accurate baseline. The guiding principle for everything we do is anatomic realignment. Get things back where they should be.
Now, about closing the wound, there's always that discussion about timing, delay versus close.
Exactly. There's a balance. Delaying closure increases infection risk, theoretically. But the face has such a fantastic blood supply, it's actually quite resistant to infection compared to other areas.
So you have a bit more leeway.
You often do. But while you're waiting or preparing, you absolutely must prevent the tissue from drying out. Saline-soaked gauze is essential. Desiccation is the enemy.
What about controlling bleeding? Facial wounds can certainly bleed profusely.
They can look quite dramatic due to that vascularity. However, it's actually unusual for isolated facial soft tissue trauma to cause hypovolemic shock. If your patient is in shock, look for bleeding elsewhere.
So how do you stop the bleeding then?
Usually, simple direct pressure is enough. The absolute key is do not blindly clamp down in the wound. You're almost guaranteed to hit a nerve or the parotid duct or something important.
So visualization first.
Always. Use suction to irrigate well to clear the field, maybe pack temporarily. Once you can see the bleeder, you can address it directly. Sometimes a little epinephrine and the local anesthetic helps with vasoconstriction too.
Let's talk about irrigation and debridement. How important are they?
Absolutely fundamental. You have to irrigate thoroughly to remove foreign bodies, bacteria, clot, and debridement is crucial to get rid of dead tissue.
What happens if you leave debris behind?
Well, apart from infection risk, if dirt or gravel gets embedded in the dermis and heals over, you get a traumatic tattoo. Permanent discoloration.
Not ideal. How aggressive should the debridement be?
Sharp debridement of all clearly non-viable tissue is necessary. However, and this is critical on the face, you must be conservative with specialized tissues. Nose, eyelids, lips, ears, hair-bearing skin. Preserve everything you possibly can.
Because the blood supply is so good.
Exactly. Even small flaps or pieces of tissue might survive on the face when they wouldn't elsewhere. If a wound is grossly contaminated, though, you'll need thorough debridement and definitely start prophylactic antibiotics.
Okay, principles of the actual repair. Any general rules?
One key thing is to generally avoid designing and using acute local flaps right away, especially in crush injuries. You need to be sure which tissue is going to survive first. Let things declare themselves,
So delayed reconstruction might be better sometimes.
or at least delayed flap design. For the initial closure, layered closure is usually the best approach. It reduces tension on the skin edges.
Does that increase infection risk? Closing layers and potentially dirty wounds.
It's a consideration, maybe a slight theoretical increase, but the benefit of reduced tension usually outweighs that risk on the face. The goal is approximation without strangulation.
And suture choice.
You want the smallest caliber that will do the job reliably, minimizes tissue trauma and suture marks. But it needs enough strength to hold things together. Commonly, 5-0 or 6-0 are used for skin on the face, maybe 6-0 or 7-0 for eyelids.
How do we handle specific injury types? Let's start with abrasions.
Simple, partial thickness ones just need some antibiotic ointment, keep them clean, maybe lotion later once epithelialized. Full thickness abrasions are different. They need dressing changes until the base is stable. Then you'll likely need closure with a flap or graft.
And lacerations or avulsions.
The key there is obliterating dead space underneath. Close in layers approximate fascia, muscle, then dermis, then skin. Careful suture placement is vital to avoid cutting off blood supply.
What about drains?
Yeah, sometimes small drains can be useful if there's a potential dead space. You can improvise them from butterfly catheters or use small Penrose drains or even red top vacutainer tubes with holes cut.
Is letting things heal by secondary intention ever an option on the face?
Very rarely. The cosmetic outcome is usually inferior, maybe for very small defects in concave areas like the medial canthus, but primary closure or reconstruction is almost always preferred.
What about bite wounds? You mentioned infection risk. Can they be closed primarily?
Yes, often they can, surprisingly. The key is aggressive irrigation and debridement first, copious washing out. Then you can consider a loose primary closure. Don't close it tight.
And antibiotics are a must.
Definitely. Broad spectrum cover is needed. Something like amoxicillin clavulanate is a common first choice, or maybe a fluoroquinolone if there are allergies. And don't forget, rabies prophylaxis, assess the need based on the animal and local public health guidelines.
Beyond antibiotics for treatment, when are prophylactic antibiotics indicated?
Generally, in specific situations. Grossly contaminated wounds, if the patient is immunocompromised, if there's an underlying open fracture, if the wound is contaminated with saliva, or if there's going to be a significant delay before definitive closure,
And tetanus.
always needs consideration. You base the decision on their vaccination history, how long ago the injury was, the wound depth, the mechanism, presence of dead tissue, level of contamination. Basically follow standard tetanus prophylaxis guidelines.
Okay, let's dive into some specific anatomical areas. The scalp.
Scalp wounds often involve avulsion or undermining in that subgaleal plane. You need a good layered closure. Close the galeal layer securely with absorbable sutures. That prevents hematoma spread and helps the cosmetic outcome. Then close the skin with absorbable monofilament or staples.
Any pitfalls with scalp closure?
Be cautious with electric eye or near hair follicles. And staples can sometimes cause localized hair loss too. Something to be mindful of.
Moving down to the forehead.
Forehead lacerations, you need to be aware of the temporal branch of the facial nerve laterally and the frontalis muscle itself. Injuring either can lead to brow ptosis.
So, repair the muscle.
Yes, if the frontalis is cut, repair it with absorbable sutures. Then close the skin, usually with a non-absorbable monofilament. Forehead scars tend to heal pretty well, actually, even if they cross skin lines.
What about the eyebrow? It seems like a really important aesthetic landmark.
Absolutely critical. The rule is minimal debridement. Preserve every hair follicle you can. Align the brow margins perfectly. Layered closure is needed. Maybe absorbable, deep, non-absorbable skin sutures.
And eyelids. Always seem complex.
They are. First, always assess for deeper injury, specifically to the orbital septum or the levator muscle aponeurosis. Missing a levator injury means guaranteed ptosis later.
What else is key for eyelid repair?
Keep sutures away from the cornea, don't let them rub. Everett the skin edges slightly when closing to prevent a notch forming as it heals. And if the laceration involves the eyelid margin itself, that requires meticulous layered closure. Often 3 sutures. 1 through the tarsal plate, 1 at the lash line, 1 at the gray line. Use fine, non-absorbable monofilament and make sure the knots are tied away from the globe to avoid irritation.
What about the tear drainage system, the lacrimal apparatus?
Right, that runs from the the little holes on the medial eyelid margins through the canaliculi to the lacrimal sac. Injuries, especially medial eyelid lacerations, can damage it.
How do you check?
If you suspect an injury, You can try to gently pass a fine lacrimal probe through the punctum into the canaliculus. If it passes easily, it's likely intact. If it stops or comes out the laceration, it's cut.
And treatment if it's cut.
Usually requires repair over a silicone stent, often microsurgically. The stent stays in for maybe 4 weeks or so. If it can't be repaired or fails, a DCR procedure might be needed later to bypass the blockage.
Moving outwards to the ear, what are the principles there?
Cartilage needs careful handling. If cartilage is exposed and stripped of its perichondrium covering, it likely won't survive, so debride those bits. Small non-structural cartilage injuries might just be excised if they're devitalized.
What about the ear canal?
If you have a circumferential laceration of the external auditory meatus, you need to stent it open during healing to prevent stenosis or narrowing.
And the dreaded cauliflower ear. Auricular hematomas.
Ah, yes. Any hematoma between the cartilage and the overlying skin must be drained promptly. Then you need to apply pressure to keep the skin down against the cartilage, often using bolster dressings, sometimes tied through and through the ear. If you don't, you get that fibrosis and deformity.
How do you close ear lacerations?
Layered closure, making sure to avert the skin edges slightly, especially on the helical rim to prevent notching. Fine non-absorbable monofilament usually works well for both skin and approximating cartilage edges if needed. Hematomas can be drained via a small window cut in the cartilage from behind. It's accessible.
Okay, the nose. Complex structure.
Very. Think of it in 3 layers. The external skin and soft tissue envelope, the underlying cartilaginous and bony framework, and the internal nasal lining or mucosa. All 3 need to be addressed if involved.
How do you repair each layer?
Skin usually gets non-absorbable sutures, maybe some deep absorbable ones in the dermis first. Cartilage edges can be approximated loosely with fine non-absorbable monofilament if needed, but avoid strangling it. Mucosa should be closed with absorbable sutures.
Anything else crucial for nasal trauma?
Always do an intranasal exam to look for a septal hematoma, a collection of blood under the septal perichondrium. It looks like a bulging bluish swelling of the septum.
And if you find one?
It's an emergency, relatively speaking. Needs immediate incision and drainage, then packing placed in the nose to keep pressure on it and prevent reaccumulation. Untreated, it can lead to septal cartilage necrosis and a saddle nose deformity.
What about injuries involving the salivary glands, parotid or submandibular?
Yeah, those carry a risk of developing a collection of saliva or a salivary fistula draining to the skin if not managed correctly.
The parotid duct, Stenson's duct, seems particularly vulnerable.
It is. Remember its location. It pierces the buccinator muscle and opens into the mouth opposite the second upper molar tooth. If you have a cheek laceration in that area, suspect duct injury.
How do you confirm it?
You can cannulate the duct opening inside the mouth with a fine catheter or probe and inject saline. If saline comes out the wound, the duct is cut.
And repair.
Parotid duct lacerations ideally need microsurgical repair over a temporary stent. Lacerations involving the submandibular gland itself or its duct are often treated by marsupializing the injured duct or gland into the floor of the mouth.
Lips next. Precision seems key there.
Absolutely critical. The alignment of the vermilion board the edge between the red lip and the skin has to be perfect. Even a 1 millimeter step off is very noticeable cosmetically.
So mark it first.
Yes. Mark the vermilion border with a marking pen before you inject any local anesthetic, which can distort the anatomy. Then it's a meticulous 3-layer closure. Mucosa inside with absorbable sutures, the orbicularis oris muscle layer also with absorbable, and then the skin and dry vermilion with non-absorbable sutures.
What about tongue lacerations?
The tongue has amazing healing capacity. Small, non-gaping lacerations often heal perfectly well by secondary intention. Larger ones, or ones that are bleeding significantly or involve the edge, should be repaired in layers with absorbable sutures.
And finally, let's just revisit nerve injuries quickly.
Okay. Key points again. Assess facial nerve motor and trigeminal nerve sensory function before anesthetic. If the facial nerve is lacerated, a nerve stimulator can help you find the cut ends for up to about 72 hours after injury.
And repair is possible.
Yes. Repair requires microsurgical techniques, coapting the nerve ends precisely. However, injuries very far distal medial to the lateral canthus of the eye or medial to the oral commissure involve branches that are often too small and numerous to repair effectively.
Okay, moving to postoperative care. What are the essentials?
Routine wound care is mainly about keeping the wound clean and preventing desiccation. Usually antibiotic ointment until things are nicely epithelialized, then maybe switch to a simple moisturizer.
Suture removal timing.
Important for minimizing scarring. On the face and neck, usually around 5 to 7 days. On the scalp, where there's more tension, sutures often stay in longer, maybe 2 to 3 weeks. Getting them out promptly reduces suture marks and inflammatory reactions.
And what are the main potential complications we should be aware of down the line?
Several possibilities. Hypertrophic scarring or even keloids can occur. Hyperpigmentation or hypopigmentation of scars, stressing sun avoidance for at least 6 months to a year, is important for hyperpigmentation.
Functional issues.
Yes, scar contracture is a big one. Across joints or near mobile structures like eyelids or lips, contractures can cause significant aesthetic deformity and functional problems. And alopecia, as we mentioned, can result from cautery injury or rough handling near hair follicles.
All right, to summarize then, what are the absolute must-remember principles for managing facial soft tissue trauma, especially thinking towards board exams?
Okay, let's boil it down. 1. Meticulous hemostasis. 2. Thorough irrigation and debridement, but be conservative in specialized aesthetic areas. 3. Primary closure of facial bites is often feasible after aggressive cleaning. 4. Generally avoid designing acute local flaps the initial injury setting.
More.
5. Always evaluate ears carefully for hematoma. 6. Achieve precise anatomic approximation, especially the lip vermilion border. 7. Use layered closure, obliterate dead space. 8. Evaluate the parotid duct if the injury crosses its path. 9. Consider facial nerve repair within 72 hours if indicated.
That's a great summary. Any final thought?
Just to emphasize that soft tissue healing is complex and dynamic. Meticulous surgical technique based on these principles is absolutely paramount to achieving the best possible functional and aesthetic outcomes for patients with these often challenging injuries.